Welcome to today's webinar, Implementing a Risk Screening Tool in Primary Care for Older Adults. We have a large audience today, likely due to our exceptional speakers and subject matter. But before I introduce our speakers today, I'd like to go over a few housekeeping items and some CFN news. There will be a question and answer session that will follow this presentation, so if you could please submit your questions online during the presentation, and we'll attempt to answer as many questions as time permits. The speakers today have offered their email if we don't get to all the questions, so that you'd be able to email them directly. A survey will pop up on your screen after the webinar, so hoping you will provide some feedback for future webinars. And you'll see the URL on our screen right now, and that's where the webinar slides and video will be available for viewing probably within 24 to 48 hours. Just to look at upcoming webinars that we have scheduled, we have them either once or twice a month, and it's usually Wednesday at noon. We have the ICAP, Improving General Practice Advanced Care, and that will be presented by Michelle Howard from McMaster University. We have Innovation for Toilet Relocation and Ease Access for Frail Elderly at Home and Wearable Caregiver Posture Coaching Feedback System, and that's Talak Duda, and he will be doing that on August 9th. And on Wednesday, September 13th, we will be having a webinar on incorporating a frailty dimension into locus for seniors in a medical psychiatric population, and that will be presented by Rose Geist and Richard Schulman from Trillium. We are looking for volunteers for our board. We're specifically targeting citizen representatives. We want to have 2 citizens on all of our committees and our board, and we want to have 2 HQP, highly qualified personnel representatives, on all of our committees as well. So for more details, there's the URL below. Please apply, as we would love to have you on our committees and boards, and please feel free to tell others who would be interested. For our CFN fellowship for this year, starting September 2017, the applications have already been reviewed. We will be letting people know within the next week or 2 if they're successful. And just so that you know, our HQP program is in development, and we'll be doing a needs survey this year that will impact our future HQP programming. And we have currently 2017 Knowledge Translation Competition in process. The intent to apply is July 24th at 5 p.m. and the full application is due September 5th. Please visit our website for specific details, and feel free to give us a call if you have any questions. And please stay tuned for our new competition that was expected to be launched later this summer. We are working with partners to expand this competition, so we're hoping late summer. It could be early fall, but please look on our website and you will see details, and we will be communicating that widely, not wildly, wildly. Today we have 2 presenters. We have Paul Stoley, who leads the Geriatric Health Systems Research Group at the University of Waterloo. He directs the University of Waterloo Network for Aging Research, and he is also the current editor-in-chief of the Canadian Journal on Aging. We also have Jacoby Elliott. She holds an adjunct associate professor appointment with the University of Waterloo. She's School of Public Health and Health Systems. Her areas of expertise include care transition, patient and family engagement, healthcare service research, and knowledge translation and exchange. She is also a member of our CFN Citizen Engagement Committee. So over to you, Paul and Jacoby.
Okay.
Just take a minute.
Can you see the slides now?
Yeah.
Okay. Well, thank you very much, Carol. I'm here with Dr. Jacoby Elliott, and I think we'd like to start by expressing our appreciation to Carol and John and the others at the Canadian Frailty Network for the positive partnership we've had with them over the years, part of which was a implementation study grant we received from CFN in 2015, which is what we're going to be talking about today. And that project related to implementing a risk screening tool in primary care for older adults who may be living with frailty. So this was a project we did together along with Dr. George Heckman. So by way of outline, we'll give you a brief bit of background, talk about the implementation process that was undertaken to implement the risk screening process. And I think that's really the key part of this story, is how that happened and then the feedback we had around that. So some evaluation information, the data on the screening tool, some feedback that was received from stakeholders, and then we're a small subcomponent of our study looking at a bit of validation of the screening tool we use, and we'll conclude with some discussion and lessons learned and try to answer your questions as best we can. So the work we have done here based at Waterloo over the last number of years has, I think, pointed to the importance of a strong primary care component of the healthcare system. Primary care is what people refer to as being the gatekeeper. It's where care coordination should be happening, and it's where we would hope older adults with chronic conditions can have their care coordinated and well managed. But often we find that's not the case. Primary care is challenged by time constraints, very busy practices, and it's hard to consider all the factors and health concerns that an older adult might have in that context. Also, coordinating care involving multiple other healthcare providers, and that takes time to coordinate. So often this is not realized to its full potential. So one thing that would be helpful in such a context would be a screening approach which could identify early on those who might need further assessment or who could benefit from intervention. And if we used a standardized approach for this, then there would be consistent language used, the approach to coordinating and developing care plans might be consistent, and it would be easier to communicate among care providers. But it would have to be brief because we have very limited time in the primary care context, as we mentioned. So the two main questions that we are trying to answer was, can such a screening process be feasibly implemented in primary care? And the grant also dealt with provider experiences with that process. We're also going to be talking a little bit about the patient experience with the tool, and because we recognize the importance of that element, and that draws from Jacoby's CFN fellowship work. So we're integrating a little bit of that into this presentation. The screening approach that we proposed was based on the preliminary screener, or when it's used in the emergency department, may be called the ED screener, that has been developed by the Interdisciplinary consortium. So it takes 1 or 2 minutes to do, so it meets our criterion of being brief and we hope doable. Because it's part of the Interdisciplinary suite, then when the items are consistent with items that are used in other instruments, and it could articulate nicely to other inter-eye assessments such as the contact assessment or the home care assessment that are used widely in Ontario and other places. And what we've seen in the literature suggests that this kind of tool should cover things such as ADL, caregiver concerns, self-reported health, recent healthcare use, and this covered a lot of those bases in a rather concise fashion. So this was the approach we aimed to implement and test in the primary care setting. So there's a few questions that get asked. The result is this algorithm that stratifies the patient risk levels from 1 to 6, with 6 being highest risk, 1 being lowest risk, and based on that level of risk, then you can have further conversations about what sort of supports or additional assessments or referrals might be appropriate.
So this was our implementation process, a very high-level look at the process that we went through. We started by conducting a series of consultations to understand the current landscape in the primary care sites. We then trained the healthcare providers on the tools. We piloted the tools, and through an iterative process with the primary care sites, we made some modifications, re-implemented, and then completed the evaluation. So we used a developmental evaluation process, and we chose this process due to the iterative nature and the involvement of the healthcare providers in rolling out the project at the study site to ensure that we were implementing the tools into the current workflow at each of the sites. So I'll go through the implementation process in a little bit more detail. So again, the first step was really to understand the current context. Focus groups and key informant interviews were conducted with 30 primary care and community care healthcare providers from rural and urban settings. The interviews with healthcare providers revealed a number of themes that are displayed here on the screen and the next couple of slides as well, including engagement of older adults, information sharing, and understanding who is responsible for coordinating care. So one provider said, older adults aren't engaged as much as they could or should be. Many feel powerless, not knowing what is available to them or how to work the system. Another provider said, primary care should be the hub of care, and this requires coordination. Here are some more themes that emerged. Understanding the current referral process, identification of services in the community, and caring for older adults in rural communities. One provider said that they are getting people way too late, indicating that a process for identifying at-risk older adults sooner would be helpful. And another provider talked about the lack of information going back and forth between primary care and community care, and that there was a lot of room for improvement in this area. Through the consultations, we also learned that the primary care providers were really interested in implementing the screening tool, but we heard very clearly that they did not want to implement anything without a next step. So although the major focus of this grant was really around the implementation of the screening tool, we also needed to implement a process of coordinating the referrals after the screening was complete. So we looked at a few different online platforms that had an inventory of all of the community services in our region. And in the end, we selected Caredove, which you can see on the slide. One of the main benefits of Caredove over the other resources was the fact that it has a direct referral function that was already set up in our region, where primary care providers could refer online directly to the community services. So we worked with Caredove to create this landing page that you can see on the screen. So providers can easily click on AUA 1 and 2, AUA 3 and 4, or AUA 5 and 6, and it would direct the provider to the services that were aligned with that risk level. The second step was training. So in total, we trained 16 frontline providers across our study sites. The providers completed a 2-hour training session, which included training from an inter-eye educator and a presentation about the Caredove site. We then launched the tools, and over a few-week period, we remained in frequent contact with the healthcare providers to gather some informal feedback about how the process was going. We learned very quickly that the paper version of the screening tool was difficult to manage and that it needed to be embedded into the EMR. We also learned that providers felt that all of the service options that were available on Caredove was a little bit overwhelming. So they requested some sort of take-home pamphlet for patients where patients could think about the discussion that they had with the provider and then make decisions about the services they wanted to access. So this screen here shows what the tool in the EMR looked like. So we were able to embed the screening tool into the EMR. And then there was this yellow toolbar in everyone's chart for a patient 70 years and older to indicate the need to complete the AUA. And this is the pamphlet that we created with our SHARP group. So this is a group of older adults that work very closely with our research group. So they helped us develop this pamphlet for low, moderate, and high-risk discussions. And there's an area on the back of the pamphlet for the providers to write down some recommendations for different service options. And then we re-implemented the tool. So for the evaluation, we looked at the number of people screened, the referrals, and we also completed interviews with patients and providers. So we screened 561 older adults over an 8-month period with an average age of 78, but an age range of 64 to 96. So although we suggested screening people 70 years and older, some providers did make the decision to screen younger than 70 if they determined that it would be helpful for that patient. And we also had 59% female patients. This slide displays the overall number of people screened across our study sites. So 70% of patients are screening at low risk, 25% are screening at moderate risk, and 5% are screening at high risk. And this slide indicates the difference between the rural and urban site. So in the rural site, more people were screening at moderate and high risk by about 9%. Through Caredove, we were able to track some of the referrals. So this captures the referrals to the community support services. It does not capture referrals to home care services. That was done a different way in our region. But we can see here that many of the referrals were made for housekeeping or gentle exercise classes. However, it was interesting to see that these services had the longest wait time, which was actually about 3 to 4 months wait list for the patient. We were implementing in family health teams, so there is a number of internal programs within the primary care site. So we were also able to track referrals to those programs. And then there was a large qualitative component to our evaluation. So we spoke with healthcare providers and patients who were involved in the screening and referral process to better understand their experiences. So first I'll start with the healthcare provider experiences. So 7 themes emerged and are displayed over the next 3 slides. So overall, providers were supportive of the process, with one provider saying, "It opens up a lot of discussion. I think it makes people more honest about what their needs are. A lot of our seniors have privacy issues or say, I'm okay, and they don't want people to worry about them. So we can be more aware of what's really going on with this process." A provider also said, "It empowers our staff to make a difference in people's lives, especially with Caredove. Taking the time to go on there with the patient, I think it's forming connections and relationships." And some other themes, assessing patients and broader system issues. So one provider said, "The AUA does flag people because you're going through, you're thinking, oh, I think they're managing, but that's actually not the case. So this helps to make sure the patient has the right support." So providers appreciated the screening and referral process and learning about the services in the community. One provider said, "There was never any kind of community supports really offered before, so this process made us realize how much support there is in the community for these people." However, providers experienced some issues with time. One provider said, "If there's a way to get a little bit more time, I think it's not really the questionnaire that's the problem. It's figuring out the Caredove part. So finding out, booking those appointments, because it does take extra time because you have to have a conversation with the patient. And we also spoke to a number of patients, and 4 themes emerged. One patient indicated, I really think this process makes people more aware of the services. This gives patients access to information about so many different services, which is helpful. Physicians can't remember all of that information, nor do they have time to discuss it with you. Patients felt that they spent significant time with providers and appreciated it going through this process. One patient said there was a lot of time spent with the provider and talked about the services and how it might help or not help. For instance, she asked about the dietitian referral, and I said it would help because I don't really eat well. So again, just showing the time spent to have those conversations. Patients also talked about how they were sharing the information that they learned about services with their friends, which we found really interesting. However, for some of the patients, there were some issues experienced when trying to access the services. For instance, the long wait list, especially for some of the community support services. And we just wanted to leave this section with this quote. This is a great way to look after us old people. It's now up to the doctors and the nurses in particular. They have to make sure they refer their patients to the services. You can't make a horse drink if they don't want to, but let them know these services are available. Because it's what I hear from people is, oh, we didn't know we could go to that. We didn't know that was available. So my only remark would be to make sure everybody says, this stuff is available. Are you interested in going? And I'm going to turn it back over to Paul.
Thanks, Jacoby. So the AUA, the preliminary screener, was developed and tested by the Consortium, but we wanted to do a little bit of testing ourselves in our own hands, in our own study contexts. And so we did a small study where we compared the AUA with the clinical frailty scale, which was developed by Ken Rockwood and colleagues, and it's been quite widely used as an assessment of frailty. So this was done in 2 primary care sites where we had patients screened independently with the AUA by the nurse or medical office assistant, and the clinical frailty scale, which was done by the physician. The CFS is typically done based on a physician assessment, which is one of the reasons we chose not to use it in our study, because that, I think, would make it less feasible than the approach we chose. But we thought, now the frailty and the risk screen, they're not kind of identical constructs, but we felt they should correlate quite well together. Now, Striner, who wrote the measurement book, says that for criterion validity, you should expect a correlation between 0.3 and 0.7. Our correlation was 0.64, so we felt that was in the right ballpark, so it correlated strongly, but not so strongly that they're duplicate instruments. This was done with 31 people, and we found that the mean clinical frailty scale scores differed across the 3 AUA risk levels, and you see the bars there. So we felt this was some reasonable additional evidence of the psychometric properties of the AUA in the context in which we planned to use it. So that's pretty much most of the story, but there were, so we'll just kind of sum up with some of the key points. So, Jacoby?
Yep. So we found overall that providers really found the tools helpful. However, as we mentioned, we did experience some barriers with the implementation. So first was the issue of time. So again, the time to complete the AUA or the screening tool was not the problem. It was really quick, and providers recognized that. But it was the conversations that happened after the screening, so around the coordinating services and having the discussions with patients that weren't as feasible in 10-minute appointment times in primary care settings. We also learned early on that patients felt overwhelmed with all of the options, and that's where we were able to partner with our SHARP group to make that patient pamphlet, and we received some positive feedback with that process. And it's also important to note that our data only reflects team-based primary care models, where different providers can be completing the screening tool, not just the physician. So we can't comment yet on the use of this screening tool in solo physician practices. We did learn a number of key lessons though. So first, the tools do need to be built into the EMR system for it to be successful. We also learned that we needed buy-in from the entire care team to make the project successful. So not just the executive directors, which were usually our first point of contact at the site. We really needed buy-in from the frontline providers who would be the ones using this tool. We also had regularly scheduled touch-based times, and this was important to ensure the continued implementation process and to gather that informal feedback to make the necessary modifications. We also learned that the majority of the referrals were made to community support services, which is an important point for future health system planning. And through our patient experience qualitative interviews, we learned that patients really valued learning about the services that were offered in the community and really valued the discussions that they had with their healthcare providers.
So this project helped us very much to position ourselves for the Transformative Grant competition that CFN ran, and it gave us a lot of confidence that when we were successful in receiving that grant, that we could carry out the project. So that project is called Transforming Primary Care for Older Canadians Living with Frailty, highlighting again the key role that primary care plays as a gatekeeper to other health services, as the medical home for patients from which they navigate through their entire care journey. So if we want to pursue a goal of a more integrated healthcare system, we need to put some effort into the primary care setting. So we're going to be using these and other findings from our previous research to apply some interventions in primary care locations, both urban and rural, in 3 provinces, Alberta, Ontario, and Quebec. Interventions are in 4 categories: consistent risk screening and assessment. Again, we'll be using the AUA as the approach. And I think an additional point we should make about that is that the AUA stratifies older patients into high, medium, and low risk. So, and the approach we've adopted, and you saw it as Jacoby illustrated through the Caredove process, even those patients who are identified as being at low risk might be appropriate to refer to services for prevention and other services that would avoid coming at higher risk. So some of us in Ontario are aware of the Health Links initiative, which is focused on identifying high-risk patients and developing coordinated care plans for those high-risk patients, and that's very much needed activity. But what our hope is that by identifying people who are at low risk and who might benefit from some additional support or from an exercise program or nutrition program or so forth, we might avoid them becoming high risk later. So risk screening, the care coordination and system navigation processes. So Caredove is again our partner on that. we'll be integrating our work on patient and caregiver engagement that CFN has been actively supporting, as well as shared decision-making processes, and that element being led by Dr. Aniki Shiger from Laval University, and some technology supports, including the Caredove app, the online educational platform for the shared decision-making tools, and we aim to develop an app that can be used by patients to track their care plans and important health information. So that brings us to the end of the formal part of our presentation. So thank you very much for your attention.
Thank you, Paul and Jacoby. That was a great presentation. I think we have about 15 or 20 minutes for Q&A. So just to let the audience know, if you have questions, please send them in now. We have a few already, so I'll proceed with that. One of the questions is, did you consider including screening for malnutrition?
It's not formally. It's something that's we're kind of aware of the importance of. We know Dr. Heather Keller at Waterloo is one of the Canadian experts in that area. It's not a part of the initial AUA screen, but I think some additional nutritional screening questions could well form a part of a subsequent assessment process. So the AUA isn't meant to be the last word necessarily on the screening process. It's intended to link to other either some discussion or conversation about services and support, or to point to the need for additional assessment. So nutrition could be certainly an area that gets looked at there.
Okay. And could patients go into Caredove to refer themselves for services, or was it only in conjunction with primary care providers?
That's a great question. So when we first started working with Caredove, patients could go on to view the different services, but they couldn't self-refer. But I know that Caredove is looking into opening up a self-referral platform for some services where that would be appropriate. But definitely patients can log on to the website and view the services that are available to them. And I don't know if you noticed on the screen, but people can type in their home address, and that will narrow down services that are available around where they're living.
Okay. Was there any involvement of the CCAC care coordinators with the project?
Yes, we included CCAC care coordinators in all of the steps. So understanding the current context, we interviewed a number of community partners, including CCAC care coordinators, and as well as the follow-up, understanding after the implementation of the tools, did they see an increase in referrals, and what did that mean for them? But this was really focused on primary care, and the sites that we were working in, CCAC care coordinators were not embedded into those primary care teams, which is now changing a little bit in Ontario, but at the time of the study, CCAC care coordinators were not in the primary care sites.
Okay, I see a lot of questions coming in just around that, or comments. Here's one. It says, for the wait time for exercise program, was this because of a shortage of exercise programs or lack of age-appropriate programs?
So it was a shortage of, so it was in-home exercise programs. I should have clarified that. In-home exercise programs, so it was a shortage of resource to provide the in-home exercise program.
Okay. Oh my goodness, you're getting lots of questions. Did the physicians track the time required to complete the frailty scale?
I don't think we captured that information, which would have been helpful. Say that, you know, the AUA only takes a minute or two, and I think it would be in some ways hard to capture that amount of time because it's a rating that is based on what should be a rather comprehensive assessment. So it's however long that assessment would take would be the key part of that. Completing a clinical frailty scale wouldn't take much time, but you can only do it if you've kind of come to, you know, had some assessment of the patient.
Okay. Here's another good question. I was wondering if you considered including a social dimension of frailty on your screening tool, and if you could comment on how relevant you feel this dimension is in screening frailty.
That's a really good question, and I certainly agree that there is an important social dimension to frailty, and from my own work going back a number of years, I would have said frailty is the balance and the interplay of a complex array of biomedical and psychosocial factors. So I think for me, the ideal and more comprehensive frailty assessment should include social dimensions. And now, however, the field has kind of gone in a particular direction, which I'm not saying this is, you know, necessarily a bad direction, but the emphasis in a lot of the frailty assessments, so Linda Fried's work, Rockwood and Medinski's deficits index, focuses on the medical dimensions. I believe Melissa Andrew has developed a social vulnerability index that complements that work with dimensions that are more on the social side. So I think to really understand why a person may be at risk for continued independence, at some point you need to have conversations about those elements. They are, for better or worse, not included in the initial screen we use, but certainly would be factors that should be considered when you're undertaking further assessments of the patient. And I think it might be part of the reason why it's important in the study we're undertaking to have engagement of both the patient and the caregiver in the decision-making process, because they bring to the conversation elements of their own situation, of their background, that the clinician may not be aware of, or may be unlikely to come up in routine assessments that are done in clinical practice.
Okay. What percentage of the clients were already on home care?
Good question. I don't have the exact number in front of me. There were a fair number screening in moderate and high risk that were already on services. However, the screening tool in primary care, I guess, highlighted that physicians made a referral to CCAC and they went back and did a reassessment, and so there was sometimes an increase in services. So even though clients may have already been on services, we did see additional services being added.
Okay, so there's a question further to that, Jacoby, and it basically is asking if it did change in home care or they were having new community services, was there a reduced visit to the primary care?
I don't think we can answer that based on this study, but it may be one that we can go some way to answering in the study we're about to begin. So in the study I mentioned, the Transformative Grant will be looking at a cohort before and after implementation of the interventions and looking at their the patterns of both groups in terms of their use of services. So that may be something we could find some information on in the coming years.
Okay. Yeah, it's, trying to cover everything is difficult. Here's a question of why not complete the EFI, the CGA, to ensure a more thorough assessment. It is evidence-based, developed by geriatricians, so the language and links are common.
So you're talking about the electronic frailty index that I think is John Young has been advancing in the UK, I believe, and a more comprehensive geriatric assessment. So the key thing for this project that we're talking about is that it was about screening. It was not about a comprehensive assessment. It would be, the screen could identify those who would benefit, who would be appropriate for a comprehensive geriatric assessment, and that's the hope. The approach that gets used for that, I guess, is another question and is open for some discussion. So one option would be, as a comprehensive assessment or more comprehensive assessment, would be the RI-HC that is done for people being referred to home care. A geriatrician might not accept that as a full comprehensive assessment, but one of the things that one of the avenues for people who are identified as being a high risk is that they may be referred to a geriatrician who would then undertake the comprehensive geriatric assessment using whatever approach they chose. The electronic frailty index, I think, would be interesting to see if down the road that's possible to integrate into this somehow, but it would require involvement with the electronic record system that we haven't been able to have so far.
Well, I had a follow-up to that. It says, to the same person that asked the question, in BC they are launching the electronic frailty index CGA into primary care clinics. The PCT completes the CGA and the frailty index is generated at point of service in the EMR. This then supports the creation of a care plan and then health coaching.
So yeah, that sounds like a great initiative, and we look forward to hearing about that project as it unfolds. I think we're going to see, and I hope we see, a variety of approaches being undertaken to raise awareness of risk and frailty in a primary care context. And I think the key thing in any of those undertakings is going to be what happens to the people who are screened as being appropriate for additional assessment or services. So it's good to hear that in the BC study there will be care plans developed based on the frailty index. So our approach is to use a different method for screening, but I don't think it's necessarily incompatible with what's being undertaken in BC. Our project is going to add some additional elements to that and different methods for developing coordinating care plans and so forth. But I think the more of this work that gets undertaken in the primary care setting, the better as far as I'm concerned.
Okay. Here's another interesting question. Who would you see as responsible for covering the costs of Caredove in this model? I'm assuming if you roll it out.
Yeah, so we were very lucky here with our study site in our region. Our local health integration network has endorsed Caredove as a platform that should be used in our region. So they're the ones that are covering the cost as they see that it's beneficial to our community. So I think that was really helpful for our project, that it was something that was done at the LIN level.
Okay. Here's another question. Do high-quality interactions, for example, shared decision-making, necessarily take more time? How do we adjust for the potentially very valuable time investment and increase provider comfort with dedicating that time? It's a good question.
I think as Jacoby said earlier, a key finding of this study was that while the screening tool doesn't take much time, the conversation after it often does. And that's in the primary care setting seen as, in some respects, a bit of a challenge or a barrier to this. Well, what it's also saying is that those kinds of conversations typically don't happen in the primary care setting. So meaningful involvement of patients in care planning and decisions, I think necessarily is going to have to take some time. Our project, I think, is aimed at trying to make that process as efficient as possible. And in the study going forward with Dr. Giguère and her colleagues, they've developed some efficient methods to present treatment options and care plan options for key conditions that could help make those conversations efficient, but also better informed in terms of available evidence. So we're thinking that combined with kind of the philosophy that we've been developing through our other CFN-funded work around patient engagement and establishing a meaningful relationship between patients, caregivers, and care providers. You know, that's the direction we probably need to go. It's necessarily going to run into some implementation challenges, but our project is going, as was described here, and as it will be going forward, be done in collaboration with the primary care team. So as much as possible, we'll find ways to make the process feasible for them.
Okay. I'm trying to weave some questions here together, as there's multiple similar questions, and basically one of the themes here is how were you able to engage the primary care practices in this work?
Yeah, great question. So over the last couple of years, we've been really making connections with the primary care teams in our region. So building the relationships with the sites has been key. We also have a partnership with a consultant here in our region, Susie Gregg, and she's a primary care lead for our local health region. So she already works in all the primary care sites and works with the teams on anything related to geriatrics. So she was really a key contact that also supported our work and allowed for connections with different primary care teams. We also feel that the methods that we chose were really helpful. So having the flexible methods where we really worked with the primary care team to determine how we would implement these tools were really helpful. So we weren't going in with a very structured process and telling the teams how they had to implement the tools. Instead, we were working very collaboratively with the frontline providers to understand how we best could implement the tools. And I think that was really helpful to the success of this project.
I guess. Here's a question that hasn't been asked yet, is were there any differences between primary care providers and patient satisfaction with the screening tool and Caredove in rural versus urban? And you may not have.
I think so.
Okay.
Nothing is coming to mind. It's a great question, and I think if there were major differences, I think we would have they would have come to light more crude than they seem to have.
Okay. What were or are some of the challenges to implementing tools in primary care?
Yeah, so again, I think one of them, the challenges that we saw early on was really when we went in with a paper-based tool to start, we found out right away that that was just not manageable. So it was just taking too long to fill out the paper-based tool, and then the providers also had to follow the algorithm to determine the score. So we really needed to get it into the EMR so that the score was calculated automatically, and it made it more efficient. And I think the other challenge is really around the time. So that was really where we saw the need to pick a screening tool that would be really quick to complete. And as Paul mentioned, the AUA takes about a minute or so to complete. So it made sense for this setting.
Okay. A few people have asked, and I think we talked about this originally, if we didn't get to all the questions, would you be able to provide your contact information? And I don't know if you have it on your screen or on your slides, just for a further follow-up on questions.
I'm not seeing it on the screen, but if you're able to send, if you wish to send them or email it or post that, that would be fine with us.
Okay. And there's, of course, questions about whether the slides and the video or would be available. And so some people came on late. So yes, the slides and the webinar will be up on our website in 24 to 48 hours. And we will see if we could add the email so that if you had further questions, you could send directly to either Paul or Jacoby. So I think we're just about wrapping up here, and I'd like to thank you for answering all these questions. You've got a ton coming through. This obviously is a really interesting area and very interesting speaker, so thanks Paul and Jacoby for a great presentation. And thanks to everybody else for joining us today, and hope you can join us on our next webinar. And that ends our webinar for today, and hoping everybody has a great rest of the day. Goodbye and thanks.